I'm going to start right off with an overwhelming slide that I don't need you to read through. I'm going to give you the highlights. This is really just to orient you to the fact that as far as our clinical guidelines go in the field, you'll see number one is to use CBT, multi-component CBT. This is a strong recommendation. This is supposed to be the frontline treatment. We actually use it before we use medication if it's chronic insomnia. Now, I want you to see one thing down here, and that is that at the very bottom, do you see sleep hygiene? Sleep hygiene is the #1 disseminated treatment on the internet, and we advise people not to use it as a single component. Okay, so people like to give out a sheet. Even reputable websites have this, if you want to sleep better, here's sleep hygiene. It is not effective, and we're going to learn why later. You also see some other things that are effective, but they're conditionally effective. So we'll talk about what that means. So we really want to be using CBT in cases when we can. So what is CBT? Well, CBT in general is a treatment in which you study what is maintaining the disorder, and then you apply cognitive and behavioral strategies to address what's going on. And then you test it and test it and test it. In our case, the two components that we use are mainly stimulus control and what's called sleep restriction therapy. But we don't usually call it that because that sounds like you're restricting sleep. So we don't usually do that. You'll notice in the slide before, there was some evidence for using these two treatments on their own, and you can. In fact, in the version that we're going to learn about, it's a 4-session model. Oops, something's happening here. It's a 4-session model, and you can see that you've got stimulus control and sleep restriction therapy right up in session 1, and those are the two effective components. And you'll see the second thing on that previous slide was this brief behavioral insomnia therapy, and you'll see that in a brief where you only get behavior therapy, it's stimulus control and sleep restriction right up front as well. So, but we're going to be learning about cognitive therapy, which is the C in CBT. So the first thing that we are going to do is to make sure that they have the problem for which CBT for insomnia disorder, was developed. And that's really important because many people will listen to what I have to say today, and they'll walk away thinking that you can use these strategies to help with sleep. Not true. That's like learning CBT for panic disorder and saying, this is the treatment for wake. Any problems with wake? There's many, many different things that can happen when you're awake, and they require different strategies. Many different things that can happen with sleep, and different strategies needed. So we are only looking to see if somebody has insomnia disorder. Now, if this is not in your scope of practice to diagnose insomnia disorder, it still holds that you should know what insomnia disorder is, because that's the only disorder for which CBTI is effective. Okay. When you are assessing for insomnia, believe it or not, you don't need anything other than a clinical interview to determine if they meet criteria, because it is a disorder of complaint, and you are all experts in fueling complaints. So you're actually just going to find out what is happening with their sleep difficulty. Okay, and I'm going to tell you what you need to know in a second. During treatment, you're going to use actually a sleep diary. And that surprises people. Some people think that you need to use an EEG. We use the EEG, the overnight EEG, and many, many, many different sleep disorders, definitely not insomnia. It's against practice parameters. It's a lot of money to spend to hear, oh yeah, you're right, you don't sleep well. So the other thing that you're going to be doing during assessment is to look for other sleep disorders and comorbid conditions. Now, I suspect everyone that's listening today, your business is what I would call comorbid conditions: depression, trauma, anxiety disorders, whatever we're talking about. So you're looking to see what else they have. So you're probably already doing that, and then you happen to look for other sleep disorders, substances, and medications. Now, this is the DSM criteria, but I'm just going to like pull out some of the major things that you should be thinking about, because not everyone who's listening, it's within their scope of practice to make the diagnosis. Here are the crucial elements to an insomnia disorder. The idea of a complaint of being dissatisfied with falling asleep or staying asleep or both is a symptom that can occur outside of a disorder and within other disorders. So that's not really the hallmark, okay? This sleep difficulty has to be chronic. So that means that at least 3 nights or more of the week, you're going to have difficulty falling asleep, difficulty staying asleep, or both, okay? And this will occur for at least 3 months, but most likely much, much longer than that, okay? And in addition to that, it's causing daytime problems, okay? So it could be a variety of different symptoms, including like mood symptoms, fatigue, cognitive symptoms. And that's why a lot of times people miss this diagnosis, because they hear that and they're like, oh, it's depression, and it's not. Of course, the main problem you could have is distress. That could be the main issue, okay? Now, as far as whether or not it occurs exclusively during another disorder, you can have another sleep disorder. But I want you to imagine something like when they have parasomnia written down. So something like nightmare disorder. What if you only have trouble falling back to sleep if you have a nightmare? On nights you don't have a nightmare, no problem. But nights you do have a nightmare, lots of problems. Well, then we can attribute it pretty obviously to that issue, right? If your insomnia is specific to whether or not you're taking a certain medication, and when you're not on the medication, you don't have the insomnia, again, you would not do CBT for insomnia. And as far as mental disorders or medical disorders happen, insomnia disorder often happens comorbid to these disorders, morbid with these disorders, right? So you can have depression and insomnia disorder occurring at the same time. And that is the norm. It is more often the case than not. So the only way that you would not make this diagnosis is if that mental disorder completely explained it. So a good example would be like the nightmare disorder. Think of it this way. What if you have nocturnal panic? You have panic disorder, but you only have insomnia, you only have difficulty regaining sleep if you had a panic attack, then that would not be grounds for insomnia disorder.